Hello, I'm Anthony Chan. I'm consultant rheumatologist from Reading in the United Kingdom, and I'm reporting here from ACR 20. One of the interesting areas that have been looked at in the ACR and in terms of the sessions, presentations, and posters is the area of patient-reported outcomes, or PROs. Now, many of you may be using PROs in your clinic. Often it's used as a research tool, but what we have seen in the presentations and posters is the use of PROs in terms of clinical practice, in terms of informing our treatment choices, in terms of assessing our treatment outcomes. There are a few posters, but I wanted to highlight to you poster 169, which looked at the use of PROs, patient-reported outcomes, in psoriatic arthritis. Now, we have clinical scores that we use in our clinic to measure objectively the patient's disease activity in psoriatic arthritis, such as the minimal disease activity or low disease activity scores. We also have the DAPSA score. We also have the CDAI score, and so we have a few of these scores that we use. Now, if what we have learned from the COVID-19 pandemic is that often we found it difficult to meet our patients in clinic because due to the isolation or the shielding or the social distancing that we had to do a lot of our clinics virtually. Now, when we do our clinics virtually, one of the problems that we face is that we can't physically examine our patients in terms of assessing the number of tender and swollen joints. So this study, I think, is quite useful and practical as well because they use patient-reported outcomes to see whether they correlated with the clinical scores that we would have done in clinic. And they use two scores. Firstly, the score called PSAID-12, and the other score is called the RAPID-3. Now, they use these two scores and they then try to correlate to see how well they perform against the clinical scores the ones that we use in our clinics, such as the MDA, LDA, CDAI, and CDAPS score. And what they found, there was a very strong correlation between the use of the patient-reported outcome scores and the clinical scores that we'd have used in clinic. So the RAPID-3 and the PSAID-12 correlated very well with the LDA, CDAI, and CDAPS score. The RAPID-3 was very sensitive and effective in terms of detecting near remission scores in patients. So in patients who did very well in terms of their treatment, when they did the RAPID-3, that correlated really well with the near remission scores. And the PSAID-12 score also did well and had a sort of wider range of sensitivity and picking up a more global view of the patient's condition, again correlating with the moderate scores on the LDA, CDAPS, and CDAI scores. So I think this whole area of PROs is one that we should be thinking about how we can implement it in our clinic. Now you might be using paper scores or electronic scores, and a lot of these scores can actually be completed at home prior to the patients attending your clinic. And you could then spend more time in clinic doing the physical examination, but having a whole rich data about their function and their performance at home in terms of their condition, like psoriatic arthritis, and how that correlates to their physical examination. Not only in the time of COVID, but I think beyond COVID, when things hopefully start to return to normal, we should be considering how we can use PROs in our clinical practice to guide our treatment decisions and to guide our treatment outcomes. I'm Anthony Chan. Thank you for listening. I'm reporting from ACR 20. Thank you very much.